Hi folks, Dr. Tom Meade. Welcome back to a second edition of our special show concerning painful foot and ankle disorders. In our first show, we had an expert panel discuss everything from total ankle replacement to posterior tibial tendon dysfunction, other painful disorders. We just hit the tip of the iceberg. So I have Dr. Keith Wapner, guest, visiting with Dr. Lori Barnett, Steve Brigido, Ed Schwartz, and Jason Rudolph to answer our questions. At the end of our first show, we talked about high-heeled shoes. Is that myth or reality, Dr. Brigido? Do high-heeled shoes in women or men, some no discrimination here, cause bunions?
Well, I think I think they can contribute certainly to the pain and discomfort of a bunion, but when you initially look at a bunion deformity, you certainly have to look at the foot type and the patient's hereditary factors that contribute to the foot type that he or she has. And that's the predominant factor that will predict as to whether or not that patient will get a bunion or hammer toes or conditions of the such. So while shoes certainly can help accelerate the progression of a bunion and they certainly can help increase the pain of a bunion, the predominant factor that causes a bunion deformity is your hereditary foot type.
Did cave women have bunions?
Yes.
How do you know?
Well, let me say this. People that were to hypothetically walk around bare feet all day long can certainly develop a bunion because of the way the foot functions. Pronation and supination, which is the foot rolling in and rolling out, and the amount that your foot does that in proportion to what is quote-unquote normal erectus will contribute to the amount of stress that goes along the first metatarsal, which will make it protrude and form a bunion deformity. So shoes can certainly, again, contribute, but are not always the main cause.
Great answer, Steve. Jason, let's attack the fungus question. There's people that get a little bit of fungus. There's people that have these thick, quarter-inch, ugly toenails. Is it just a cosmetic problem? Is it painful? And one of the gentlemen in the audience had a great question. He's a little frustrated with it. He was considering some of this laser surgery. How do you treat it? What's the success rate?
Why don't you ask me the question about the posterior tibial tendon? That's really more my But I mean, honestly, fungus problems.
We could phone a friend.
I phone Dr. Schwartz.
Okay, Dr. Schwartz, do you treat more of that?
I treat some of it. Not all nail thickening is a result of fungus. When a person comes in with a toenail fungus, the nail needs to be cultured. A specimen of the nail needs to be taken, sent to a lab, and get a report back. Are we actually dealing with a fungus? And what's a fungus? A fungus is a germ that lives on our skin. It's the same germ that can cause athlete's feet. It loves an environment that is warm, dark, and moist. So people that wear socks and shoes are going to be prone to getting a fungus. A person who gets a fungus infection does not necessarily have bad hygiene. It's just a product of their body's ability to fight that fungus off. And if it gets into the nail can become very discolored, very thick. It could present a problem in the fact that in diabetic patients, it could lead to other types of infection. They can get ingrown toenails that can get infected. The fungus can spread to their skin. They can get cracks in their skin, which could then become infected. So for some individuals, it's a little bit more of a health issue than it is for other people.
What's your favorite treatment, Ed?
The gold standard still is an oral antifungal medication, something like Lamisil.
Any experience with this laser treatment?
I've had no experience with it. Looking into it, it's not something that I think is still a good option for most people.
Jason?
I can contribute one thing to the fungus question, I guess. And it goes back to what you initially brought up at this meeting was this false advertising, trying to bring people into your clinic based on laser sounds so wonderful that it's going to cure everything. If you read the small print in any of those ads, I think they all have to say that it's FDA approved for short-term relief of a fungus. Well, nobody wants short-term relief if you're going to spend the amount of money they're talking about here. So if it, one of those things that stands true everywhere, from fungal nails to anything else in orthopedics, if it sounds too good to be true, it is.
Jason, back to you with a really difficult question. When I did trauma for many years, one of the worst fractures that I had to treat was a calcaneal fracture, a heel fracture that, if I remember what Dr. Wapner taught me, it was called an aviator's fracture early on due to, I don't know, early 1900s planes crashing or something. They're hitting the rudders and coming down.
Tailless fractures and aviators.
Oh, tailless fractures. See, I knew I didn't.
Never paid attention.
It's really not my fault. He wasn't a good teacher. But anyway, one of our members of the audience had a calcaneal fracture closed, not open, requiring surgery, got infected, and then required subsequent foot surgery, tarsal tunnel, perhaps the equivalent of carpal tunnel or nerve compression in the foot. And I guess the advice she received was she was at high risk for further infection. Is that correct? So they put that off. What's the risk of infection? Tarsal tunnel, does it all need surgery? How do you treat that?
So to skip those easy questions about calcaneal fractures and tailless fractures, and to go to the easy problem, anytime you have an infection in orthopedics, or any kind of foot and ankle surgery, it's one of the things we all worry about. Skin and the infections can vary. A simple little skin infection after surgery is something that pretty easily treated with antibiotics. In the calcaneus, which is your heel bone, the bone is 1/8 of an inch below the skin, so there's not a lot of room there to mess with. Once the infection hits the skin, it can get down to the bone pretty quickly, and if it gets into the bone, then it's a real problem, because you can take all the antibiotics in the world and it doesn't kill the bacteria that's sitting in a bone. So that usually requires another surgery to clear out any dead or infected bone in the heel. Once you've had that, theoretically, if the skin closes and go through the procedures to cure the deep infection in the calcaneus, I'd say once everything settles down, it might be a year afterwards, and I don't think you're at risk for having a soft tissue surgery like a tarsal tunnel surgery where you're releasing a nerve. I think everybody would be hesitant to talk about any kind of major surgeries like joint replacements in people that have had deep infections in the past. But a soft tissue surgery where you're releasing the tarsal tunnel nerve, which is similar to a carpal tunnel, but for every one tarsal tunnel I see, I'll probably see 1,000 carpal tunnels. So it's a pretty rare problem, and even more rarely requires surgery.
And plus, I think there's some other host issues. If you are at a higher risk for an immune problem, if you're diabetic, if you're a smoker, I think all those things contribute to an increased infection rate. So the other pressing question is plantar fasciitis. What is it? How do you treat it? How do you differentiate some heel pain from plantar fasciitis? What's the role of a Coke bottle on your foot, stretching, ultrasound, and surgery? And Dr. Barnett is going to help us answer that question after this break.
We live in a fast-paced, on-demand world where everything is available at a moment's notice. Now your healthcare can be on demand as well. Coordinated Health, the name you trust for superior care, now offers Care on Demand, where you can walk in, no appointment necessary, and receive immediate care for all non-life-threatening emergencies. With specialists in primary care, orthopedics, cardiology, and women's health, and locations throughout the Lehigh Valley and Poconos, quality care is never out of reach. Coordinated Health, your prescription for better health.
Does hip pain affect your daily activities? Stryker's revolutionary new anatomic hip replacement may help.
The issue is quality of life. I think it all boils down to that.
Call 1-888-STRYKER to find out which Stryker anatomic hip option is right for you. Stryker's new anatomic hip is designed to help restore your range of motion so you can get back to what's important to you. For details about Stryker's anatomic hip options, call 1-888-STRYKER or visit aboutstryker.com.
Heel pain affects many patients. The classic pain, I get out of bed in the morning, I can't take a step, somebody's sticking a nail in my heel, hurts like heck, how do you treat it? I don't have the answer, but maybe Dr. Barnett does.
Well, first to understanding heel pain is that it's not just the heel, it's a sheath of tissue that starts at your heel and it's attached at the heel and goes into all the metatarsal heads or the knuckles of the foot. And because it's supporting the entire weight of your body, it gets thickened and we get little micro tears, and you get pain and issues with it being very tight and difficult to move, and it hurts to walk on. The difference between foot injuries and, say, elbow injuries is it's much easier to rest an elbow than it is to rest a foot. And you need 3 components for plantar fasciitis. Basically, some kind of a support or minimizing the motion of that poor plantar fascia that's overworked and overused. You need to do stretching so you can change the architecture and help that plantar fascia, help those micro tears heal. They become fibrotic or thicken like scar tissue, and you need to work all of that tissue out. So that's why Dr. Meade mentioned about rolling over a Coke bottle. You can use something a little fancier, and like a Poland Spring water bottle that you freeze, and it has the little ridges on it. So that makes it really nice, and it massages the foot. It actually stretches out that area. And a biggie is calf stretching. That is one of the most common areas of tightness, the Achilles tendon, or the back of the ankle being very tight, and that needs to be stretched with manual stretching. You can use night splints, and physical therapy can be really helpful with that.
I'm going to let Dr. Wapner answer that, but before that I want a 2-word answer from every panelist, starting with Jason, and we'll end up with Keith, and he'll answer the question. Out of 100 patients with plantar fasciitis, how many ultimately need surgery, and what's the average time until the pain goes away? Jason, in your practice.
Less than 1 and 3 months for the pain to get better.
Less than 10%, and anywhere from 3 to 6 months.
Steve.
Well, I'd say less than 5 to 10%, 3 to 6 months.
Lori.
I say less than 5 to 10%, and for it to be 100% better, no pain at any point, I'd say up to a year.
Yeah, consistent answers. Keith?
Yeah, I would agree more with you. It's interesting. If you look at some of the studies on plantar fasciitis, the average time for a patient to get better is 6 months. That means 50% of you are going to get better in 6 months, 50% may take longer than 6 months. Being at the university, most of the patients that I see with plantar fasciitis are the ones that didn't get better in the 6 months, and then they're being sent down to us. And if you're patient and you still follow these other non-operative modalities, 99% of the time you're going to get them better. The interesting thing about the night splints, if you look at the history of that, back in 1986 or 1987, when I first started practicing orthopedics, we had 2 residents in our program that wanted to run marathons and triathlons. And I tried to convince them if they wanted to go 26 miles, they should just buy a car. But Tom wouldn't listen, and he was one of them. And so he had this horrible night pain from his plantar fasciitis, and he and his fellow resident, Pete Sharkey, they would get up in the morning and they would be gimping around and they couldn't walk. And so he came up with the idea, and they came to me and said, well, what if we tried a night splint? So we got night splints. I don't remember if it was for you or for Pete.
Well, it was for Pete because he was my junior resident,
right.
so I
tried
practiced
him
on
first.
him.
Yeah, tried on him first.
We put him in a cast, and we casted him at night.
We casted him at night, and then we found out that it worked. And so based on that, we came up with the idea, well, why don't we start making some night splints for some of these patients that we were seeing. And actually, so the whole etiology, when you hear about these night splints for plantar fasciitis, it was because he wouldn't buy a car to go 26 miles. That's how the whole thing started.
But really, that's the standard of care, thanks to Dr. Wapner. Now, if you go online, a night splint really came from a bunch of guys that didn't know any better, had too much time on their hands at Methodist Hospital during our rotation to run around. Another great question from the audience is, in hip surgery, you can have a hip fusion, and there are cases of converting that to a total hip arthroplasty. So instead of walking around with a fused hip, you can have a total hip. Occasionally, a knee fusion can be reversed. A patient in the audience had a ankle fusion, and she still has pain. So there's really 2 questions. What are the reasons for residual pain after an ankle fusion? What are the treatment remedies? And is conversion to a total ankle an option? I'll bounce that off Steve.
Well, the first question is why do you still have pain after an ankle fusion? So the first thing that we would look at is make sure, did the ankle fusion completely heal? You want the bone, the tibia and the talus to completely knit together. And if they're only partially knit or not knit at all, then that can be a reason as to why you can still have a little friction causing your pain. So once we get that answer, we can also then determining how that surgeon did your ankle fusion, we can look at, and in our institution, we've converted several patients that have had ankle fusions to ankle replacements, but several factors dictate why and if we can do that. The first being is, how is your anatomy? The second is, how is the quality of the tissue surrounding the ankle? The third is, and all of these are just as important as the other, what is your body type? What is the anatomy of your leg? How does your limb sit in relation to the rest of your body? And when we look at all of those factors, then we can make an educated guess or an educated determination as to whether or not we can convert your ankle fusion to an ankle replacement. But to say unequivocally that yes, a patient can have it, or no, they can't, it isn't fair to do, because it all depends on the particular situation that is going on in your ankle. The fact of that is that ankles have been around since the mid-1970s. Now, certainly they have gone through many, many generations of improvement over time. And when you look at the current generation of ankle replacements that we're utilizing, sure, they are certainly newer than that of the current generation knee replacement or hip replacement. But there are different situations, and you want to see a surgeon who, if you're inquiring about an ankle replacement, one of the most important things you can do is to see a surgeon like Dr. Wapner or like our team at Coordinated Health that is doing a lot of volume in ankle replacements. You don't want to be talking to a surgeon who has not done any, or has only done a handful, because the technique to converting an ankle fusion to an ankle replacement is quite challenging. If you're going to take the time to do that, and you're going to go through that process, you want to make sure you give yourself the best opportunity to get better.
Achilles tendon pain. Anyone in the audience have Achilles tendon pain? Yes, ma'am. Yes. From what? Tendonitis. So the question, I'll repeat the question, is after extensive non-operative treatment of stretching, a patient has Achilles tendonitis. Would she fit into that 5% of people that need surgery? Or are there any other options for her, Dr. Barnett?
And are you wearing a functional orthotic with that? Are you? There's a technique called the Graston technique.
Oh, that's
Have you
started.
Done that? Did that?
It's very similar to what I think the Viet Cong.
Yeah, it's not exactly waterboarding, but it should be outlawed. Is that what you're saying? The problem with the Graston is that it depends on the handler sometimes. It can be pretty aggressive, but basically what we're talking about is a technique that is like a massage technique that uses instrumentation. And certainly the Achilles tendon can be overstretched and really irritated. And sometimes that really needs to be looked at, the pathology needs to be looked at. And Dr. Brigido can probably talk about the surgical, sometimes surgery is required to clean up that Achilles tendon to help with that when the stretching is just irritating it.
Some of the most annoying problems in the foot are calluses, corns, and even plantar warts. I saw that in a lot of athletes. They're small little problems, but they annoy the heck and they disrupt the quality of life. How can you tell the difference? How do you treat them? And we're going to ask Dr. Schwartz right after this message to explain that.
Whether you're an athlete missing an important game or a grandparent struggling to keep up, nothing is more frustrating than being sidelined from your own life because of pain. Dr. Anthony Favello can take care of your orthopedic problems and get you back to living your life faster. As Hazleton's top orthopedic surgeon, Dr. Favello caters to the needs of the greater Hazleton community, where he was born and raised. Dr. Favello provides exceptional care in all areas of orthopedics, ranging from simple sprains to more complex conditions and procedures. Dr. Favello, orthopedic care from a name you trust.
Hello, folks. Topics to improve your health and quality of life. Please join me. You won't be disappointed. Folks, we're back, and the bottom of the foot has a lot of surface area. You can have one little splinter that affects 1% of the bottom of the foot, and it incapacitates you. The same is true of corns, calluses, and even plantar warts. Over the years, I've had folks ask me, how do you get rid of them? I don't have a good answer, and I'm sure a bunch of the foot and ankle surgeons on the panel see that. Ed, what's your treatment for that? How often do you see it? What's the difference between that and a corn on the bottom of the foot?
A corn and a callus are basically the same thing. It's a matter of where they're located. It's a thickening of the skin. The skin is trying to protect a bony prominence underneath it. If that skin gets thickened on the top of a toe, for example, as a result of a hammer toe, it's called a corn. If that skin gets thickened on the bottom of the foot beneath the metatarsal head because it's trying to protect that bone, it's called a callus. It's basically the same thing. It's just a matter of where it's located. And they can become quite painful. The reason people develop calluses on the bottom of the foot are typically because there's a weight-bearing imbalance. One particular bone is getting more pressure than it should be. The weight is not being distributed evenly. Well, why does that happen? Well, it happens because of a flat foot, could happen because of a bunion, could happen because of a hammer toe. There's a variety of different mechanical reasons or structural reasons why people can develop those things. A wart is different. A wart is actually caused by a virus. Just like we can get a sore throat from a virus, well, there's a certain type of a virus that can cause a wart. And that wart lives in the most superficial layers of the skin, and it can become quite irritating. It's like taking a small pebble and taping it to the bottom of your foot and then walking around on it. It could be quite uncomfortable. Most commonly, warts are taken care of usually with topical medications. That the wart is debrided and some type of acid material is usually applied to the wart, and most of the time that can eradicate the wart.
How about cutting a potato off and duct taping it to it? Does that work, Ed?
I've had people come in with banana peels taped to their foot, and that doesn't work either.
Good. I'm going to move on from that and ask, Jason, Morton's neuroma. What is a neuroma? And again, that can be another devastating problem with pain in the forefoot. And is surgery helpful? I see it in runners a lot. How often does that help them? How long does it take to get over?
Well, neuroma in general, a neuroma means scar tissue is built up around a nerve. And you can get neuromas in different parts of the body. In the foot, you can see neuromas from previous surgeries where a skin incision goes near a nerve and that nerve then develops scar tissue around it. A Morton's neuroma is a specific, usually referred to a specific neuroma in the bottom of the foot, either between the second and third toe or the third and fourth toe. And there's nerves, which are the most fragile substances in the body, that run from your spine. They break up and get smaller and smaller and smaller until they get to the tip of the toe. Well, it just so happens that in the front of your foot is exactly where one of these nerves divides and goes to the two toes. Runners or people that wear a lot of heels or seem to put a lot of pressure on the front of their foot pound on that front of the foot repetitively, and that nerve then can develop some scar tissue around the nerve itself. Like most things in foot and ankle, we try to treat almost everything non-operatively first. So again, talking orthotics or pads or something to take the pressure off of it, talking injections, like a steroid injection around the nerve to quiet down the inflammation. However, if that nerve is just embedded in scar tissue and incredibly painful and fails all these simple treatments, there is surgery. And in general, the surgery for this nerve, which is unique to most other places in the body, we usually will just resect the nerve, just take it out. You end up with sometimes a little numb spot between the toes, but you get rid of the pain. Now, that's not something you do in the knee or the carpal tunnel. You can't just remove the nerve. But in the front of your foot between two toes, that's usually the simplest way to treat it if it's failed the non-surgical treatment.
Out of 100 Morton's neuromas, how many need surgery?
Again, it's a tough question because a lot of people are self-treat.
We're here for tough questions.
Well, I'd say that's higher, definitely higher than the plantar fasciitis.
Okay.
Maybe 25%.
Anyone else? A lot of experience on the panel?
I'd say 25 to 30% require surgery.
Does it work?
Most of the time it does.
Yeah.
Yeah, I mean, but if you look at what's written up in the literature, it'll tell you that if you do surgery on an neuroma, 80% of the time the patient's going to do very well. About 10% of patients will do better. and 10% of the time it just doesn't work. And we think probably the reason it doesn't work is it's really phantom pain. Like you're taking the nerve out, you're cutting it, you're essentially amputating the nerve. And similar to a person with an amputation of a limb, they'll say, well, I still feel my leg even though their leg's been amputated. So I think that in some situations the residual pain really is phantom pain.
I think it's real important to make sure it's a neuroma too. I mean, the front of your foot, probably at least part of that 20% that fail, it's because you're not doing the right surgery.
How do you diagnose it?
It's a little tricky, believe it or not. Even though you're talking about little toes here, one of the ways to diagnose is obviously just feeling it, and you want to make sure that the pain is really over the nerve and not over the metatarsals or the knuckles in the foot, like Dr. Barnett was just talking about, because they're very close together, and sometimes it's hard to separate the two. A lot of times we do these steroid injections, and we're not doing it to hurt you. You're doing it not only for diagnosis or for treatment with the steroid, but a lot of times to diagnose it. If you put the steroid or the numbing medicine over the nerve and the pain's resolved, pretty good chance that that's coming from a neuroma.
Do you require an imaging study, an MRI, to visualize it before you operate?
I think MRIs are probably more helpful to rule out other problems, not necessarily to see neuromas, but to make sure there isn't something else going on.
With the obesity epidemic in America, metabolic syndrome is rampant, and diabetes follows soon thereafter. A big problem is peripheral neuropathy, nerve pain, numbness, and even wounds. My guess is in the foot and ankle world that could consume a lot of resources and energy, treating diabetics and ulcers and wounds and that sort of thing. Any of the panel members have experience or special interest in diabetic feet? Do you, Keith?
Yeah. No, we do a lot of work in diabetic foot and ankle care, and probably the first step is patient education. A lot of the bad complications that we see in diabetics can be prevented with patient education and taking care of their feet, knowing to look at your foot. When you're a diabetic and you develop a neuropathy, the problem is you don't feel things. And so if you step on a tack, you may not know it. And we see patients, they stepped on a tack, they come in 2 days later with an infection, and there's this tack on the bottom of their foot, and simple things like that. So teaching a patient something as simple as sitting down, taking your socks and shoes off, looking at the bottom of your foot, looking between your toes, looking for corns, calluses, things like little lacerations, things like that can be very, very helpful.
Well, thanks. We're probably running out of time, but like many things, prevention is a lot easier than treatment of these issues. But
Exactly.
I want to thank really a world-class panel of Dr. Wapner, Dr. Barnett, Dr. Brigido, Dr. Schwartz, Dr. Rudolph for being here today answering these questions. And again, I think after 2 shows, we've just hit the tip of the iceberg. So after the show, you're welcome to ask some questions. I want to thank the audience for coming. I want to thank you for your time and listening. Join us next time. Hope you learned something today. It was a lot of fun. Join us on our next show.